Okay, so we'll start now. Can you still hear my voice clear? Okay. Today's session will be about the anatomy of the orbit and the extraocular muscle. This lecture is very important in the exam, and almost always questions appear in the exam from these topics. This is because it is just pure anatomy. And even you may figure out that there are some textbook or there are some AI textbooks which start the anatomy discussion by the orbit, not by the eyeball and the cornea. Let's start to understand the basic concepts about orbital anatomy and the related extraocular muscles. And I hope that the lecture will be handy and useful for you. So, what is the orbit? The orbit is a pyramidal bony cavity. So it is a pyramidal bony cavity in shape. So by saying it is pyramidal, meaning that it has an apex and its base. So what will make the apex? It is the optic foramen, which transmits the optic nerve. And what makes the base? It will be the orbital rim. So the orbital rim is formed of, or the orbital rim will constitute the base of the orbit, while the optic foramen will make the apex of the orbit. And by saying pyramid, you may think of pyramids of Egyptians, so you may think it is of 3 walls. But the surprise here is that it is a quadrangular pyramid, so it is formed of 4 walls. Can anyone see the slide, or it is just Dr. Saleh? Okay, Dr. Saleh, try to restart your browser or enter from another network. So maybe mobile network or the DSL, whatever network you are using in your country, you may think of switching it because sometimes the slides or the screen share doesn't work in all internet networks. Okay. So the orbit, Dr. Duha can see but no sounds. Dr. Duha, follow the instructions. Okay. So the orbit is formed from 4 walls. It is made of the roof superiorly, the floor inferiorly, the lateral wall, and the medial wall. So if we have a section of the skull, as you can see here, you will find that this is the orbit, as this is an anteroposterior view and this is a lateral view. The orbit is made of 7 bones. It is the frontal, sphenoid, lacrimal, ethmoid, maxilla, and zygomatic bone. So if we remove the roof of the orbit and we see the orbit from superiorly, you can see that we cut here the superior rectus and the levator palpebris superiosus muscle in order to see the optic nerve and the globe. So here is the orbit. It's a pyramidal in shape with its apex made of the optic canal. And the base is formed of the orbital rim. Here is a lateral view. So here we removed the lateral wall. You can see again that the optic canal making the apex of the orbit, while the base is made of the orbital rim. It is a quadrilateral pyramid, as we said, meaning that it has 4 walls. So it has a roof, it has a floor, it has a lateral wall, and it has a medial wall. Here is the roof or the superior orbital wall. Here is the floor, which is the inferior orbital wall. Here is the medial wall, and here is the lateral wall. As you see, it is a quadrilateral pyramid. So what is the relation between, or let's just see what is the direction of the base and the apex. So the base is directed anteriorly and slightly lateral and slightly downward. So both of the orbits of both eyes are not parallel to each other. So they are just directed slightly lateral and downward. While the apex is the reverse. So the apex is located posteriorly and medially toward the nose, as you can see here, and it is elevated slightly upward above the level of the orbital base. Sometimes it is asked a question as asked in the exam, what is the widest area of the orbit? So it is like at the orbital rim? The answer is no. As the widest area of the orbit, it is just behind the orbital margin or behind the orbital rim by 1.5 centimeters. 1.5 centimeters is only this is the widest part of the orbital margin, as you can see here. Dr. Sayed, if you cannot see the video, just follow the instructions that I have just mentioned to Dr. Saleh. So try to restart the browser, try to clear the cache and clear the cookies of the internet browsing of the Google Chrome, and try to restart the router if you have one. So again, as we said, the orbit is made of 7 bones. So they are the frontal here, and the maxilla, number 2. Here is the maxilla, and the bone that join the frontal and the maxilla, it is called the zygomatic bone. Then we have the sphenoid bone, we have the ethmoid bone, lacrimal bone, and finally the smallest bone which share in the formation of the orbit is called the palatine bone. What are the 7 bones of the orbit? So sometimes in the MCQ you are given multiple options about the bones that make or share in the formation of the orbit, and only one is wrong. So you need to know what are the exact bones that share in the formation of the orbit. So we have the ethmoid bone, lacrimal bone, maxillary bone, palatine bone, zygomatic bone, sphenoid bone, and the frontal bone. So, what are the relations between both orbits? Are they parallel, as we said? The answer is no, because only the medial wall is parallel. So the medial wall of the right orbit and the medial wall of the left orbit are parallel to each other. On the other hand, the lateral walls are forming an angle of 90 degrees, so they are perpendicular to each other. The lateral wall of the right and the lateral wall of the left are perpendicular to each other. The angle between the lateral wall and the medial wall is about 45 degrees, as you can see here. And if we have a line bisecting the right orbit and the left orbit, then this line will be called the orbital axis. If we join the two orbital axes together, they will form again an angle of 45 degrees. So bear in mind these numbers because sometimes they are asked in the exam. So just remember that the medial walls are parallel, the lateral walls are perpendicular, the orbital axes are 45 degrees, and the medial and lateral wall is 45 degrees. I hope that it's clear. So here is the medial wall, and the medial wall are parallel. The lateral wall here and the lateral wall there are perpendicular to each other. The angle between the medial wall and lateral wall are 45 degrees, and the angle between the orbital axis of the right eye and the orbital axis of the left eye are 45 degrees. The posterior margin of each orbit and the optic foramen and superior orbital fissure are located medially to the eye. So the eye is located laterally, as we said that the orbital opening is located lateral. So what are the medially to the eyeball will be the optic foramen and the superior orbital fissure, as we will see later, and the orbit itself, or the posterior margin of the orbit. Just to a quick reminder about some basic data that we mentioned in the first lecture. So the height of the orbital opening is 35 millimeter. The width of the orbital opening is 40 millimeters, while the depth of the orbit is 40 millimeter, and the interorbital distance is about 25 millimeter, and the volume is about 30 milliliter. So these are just some quick reminders about the orbital dimensions. I hope that you remember it. So what will be our strategy in the orbit? What shall we study? So what is important in the orbit is to know what is every structure. So you need to know what is the anterior margin, the roof, the floor, the medial wall, and lateral wall. So you need to identify each one of them. You need to know what are the bones that make each one of them. You need to know what are the important anatomical structures related to each one of them. So once we finish them, then we will need to know some important data about the foramens and the fissures of the orbit, and this will be the end of the orbit. So the first important anatomical landmark in the orbit is the orbital rim, or what's called the orbital margin. So the orbital margin is just the anterior edge of the orbit. And what are the bones that make the anterior margin or the orbital rim? It is only three bones. It will be the frontal bone, the maxillary bone, and the zygomatic bone. Here is the frontal bone, making the upper part of the orbital margin, and the maxillary bone, making the medial and the part of the roof, part of the floor, and the zygomatic making the part of the floor and the part of the lateral wall. Hello, Dr. Taysir. So, Dr. Taysir, was you or have you been able to watch the slides before or the previous lectures? Dr. Taysir, I'm asking you, have you been able to watch the previous lectures live? Okay, so we will continue. So the wall or the rim of the orbital margin is spiral, meaning that it is made of, here we see that this is the frontal bone, this is the zygomatic bone, and this is the green one is the maxillary bone. But it is a spiral, meaning that the inferior margin, here is the inferior margin of the orbital rim, it is continuous with a ridge here called the anterior lacrimal crest, while as it goes from inferior to lateral to superior, making up the roof, then the roof will descend down to make another ridge posterior to the first one. It's called the posterior lacrimal crest. So this is the spiral shape of the edge of the orbital rim. And why is this making this a spiral? Because enclosed between the anterior lacrimal crest and the posterior lacrimal crest will be the lacrimal fossa, which in which the lacrimal sac will be occupying this area. So the lacrimal sac is situated between the anterior lacrimal crest, posterior lacrimal crest. So the anterior lacrimal crest is apart from the maxillary bone, the frontal process of maxillary bone, and it is continuation of the inferior orbital margin. While the posterior lacrimal crest, it is a part of lacrimal bone, and it is a continuation of the superior orbital margin. I hope that this is clear, because sometimes this information is asked in the exams. So what are the bones that making the orbital edge or the orbital rim? So we have the lateral margin made of the zygomatic bone and the zygomatic process of the frontal bone. So this is the frontal bone, it gives a zygomatic process and the maxillary process. So the zygomatic process of frontal bone and the zygomatic bone, both of them will make the lateral margin. The superior margin is made by the frontal bone exclusively, and while the medial margin is made by the medial angular process of the frontal bone and the frontal process of maxilla. So are the bones making the medial margin. It is the frontal process of maxilla and the medial angular process of the frontal bone. While the inferior margin is made by the maxillary bone and the zygomatic bone. So again, the inferior margin by the body of maxilla and the zygomatic bone, lateral margin made by the zygomatic bone and zygomatic process of frontal bone. The roof or the rim, the superior margin of the orbital rim is made by the frontal bone, while the medial margin of the orbital rim is made by the frontal process of maxilla and the medial angular process of the frontal bone. So after we know the bones that constitute each structure, we need to know what are the important anatomical structures related to it. So we have here, this is the orbital rim. This one. Here is the lacrimal fossa. This is the inferior margin, and this is the lateral margin. So what are the important landmarks here? We have this notch. It's called the supraorbital notch. This notch is between the medial 1/3 and lateral 2/3 of the superior margin. And you can see clearly that the lateral 2/3 here is sharp. It has a sharp border, while the medial 1/3 here, it has a soft border. So what is the importance of the supraorbital notch or foramen? This will be to transmit vessels and nerves by its name. So it will transmit the supraorbital vessels and nerves. And as we will see in the next lecture, we will know what are the supraorbital vessels and nerve will supply. So basically will supply the middle part of the upper eyelid and the middle part of the upper conjunctiva. Then just medial to the supraorbital notch, it will be a groove. This groove is for the supratrochlear nerve and artery, because this is the location of trochlea. Trochlea, it is a cartilaginous ring present here attached to the bone that transmits the tendon of superior oblique muscle. And this occurs, or this is present medially to the supraorbital foramen. So it will be called the supraorbital or supratrochlear groove. So it will be for the supratrochlear nerve and supratrochlear artery, which basically will supply the medial part of the upper eyelid and conjunctiva. Sometimes another notch or foramen is called Arnold notch or foramen, can be present medial to the supraorbital notch. It doesn't have to be present in all individuals, but if it is present, it will be medial to the supraorbital notch. So a question also appeared in the exams before, asking where is Arnold notch or foramen, because from its name it doesn't give a clue about its location. So they like to ask about it. So you just need to know that the Arnold notch is present in the superior orbital margin, and it present medially to the supraorbital notch. Finally, related also to the inferior orbital margin will be the infraorbital foramen. So the infraorbital foramen will transmit the infraorbital vessels and nerve. So this is all what you need to know about the orbital rim. So let's now talk about the 4 orbital walls. We have now 4 walls. Each wall is a triangle in shape, so its base is larger than its apex, except for the medial orbital wall. So this is also asked in the exams, that the medial orbital wall is the only wall that have a quadrangular walls. So it is like a quadrangle, not a triangle. Let's start first with the orbital roof. So here, what are the bones that make the orbital roof? We have first the orbital plate of the frontal bone. As we said, this is the blue one, is the frontal bone. So the frontal bone has a share in the formation of the orbital roof by an orbital plate. this is anterior, while in the posterior part near the orbital apex there will be the sphenoid bone. The sphenoid bone has three main parts: the lesser wing, the greater wing, and the body. Each part of them will contribute to a specific wall of the orbit. So the lesser wing of sphenoid here will contribute to the apex. So remember that the lesser wing is the one which you share in the formation of the orbital roof. So this is an anteroposterior view. If we remove the eyeball and the floor and contents and look to the orbital roof from below, we will see this section. So here is the nose and the nasal sinuses, the ethmoidal sinuses. And here we just removed the floor and the eyeball from below, and we are looking to the roof from below. So we will find this is the supraorbital notch, and there will be supratrochlear groove and the Arnold foramen, and this will be the superior rim. And this is the bone which make the anterior part of the roof, which is the orbital plate of frontal bone, while the lesser wing of sphenoid will share in the formation of the orbital apex. So it will share in the formation of the optic canal, and it will be present posteriorly. So the lesser wing of sphenoid is the part that share in the formation of the orbital roof. So what are the features? The important features, we have two main features. There is a fossa at the junction between the roof and the lateral wall. This fossa is for lacrimal gland. So the lacrimal gland is situated at this fossa at the junction between the upper and the lateral walls here. And medially, we have the trochlea, this fibrocartilaginous ring, which is present at the medial part of the roof, so that it is the superior oblique muscle tendon will pass through it. So the trochlea and lacrimal fossa are the features of the roof. The roof is separated from the surrounding structures by different structures, meaning that the roof will be separated from the lateral wall, like here, by a fissure. This fissure is called the superior orbital fissure. So you can see that this is the frontal bone, or this is the orbital plate of frontal bone, and it is separated. It is joined to the lateral wall anteriorly, while posteriorly it is separated by a fissure called the superior orbital fissure. So it is separated posteriorly, while in the anteriorly it is just separated by sutures separating the frontal bone from the zygomatic bone. It is just frontozygomatic fissures. While the medial wall of the orbit, or the medial wall is separated from the roof by just fine sutures separating the different bones of the medial wall from the roof. What about the relations? So if we just removed the orbital wall, and we are here into the anterior cranial fossa, removing the roof of the orbit, and to see what are the structures that lies just below the roof. The first thing that we will notice is that there are above the roof will be the frontal sinus and the frontal lobe, as we may expect. While below we can find different structures. You need to know these structures because they are important. So just below the roof, if you remove just the roof and you see what is immediately below the roof, it will be the frontal nerve, then the trochlear nerve, and the supraorbital vessels. So here we can see this is the frontal nerve and trochlear nerve, and the supraorbital artery and supraorbital nerve. They just lie beneath the orbital roof. If you descend more down, you will find three muscles, but these muscles are below the vessels and nerves, but they are in different configuration, meaning that the levator palpebrae superiosus will be the first one behind or beneath these nerves and arteries. Below the levator palpebrae superiosus will be the superior rectus, and at the corner between the medial wall and the roof will be a cylindrical muscle pass along the axis, along the corner, and the junction between the medial wall and the roof is called the superior oblique muscle, as you can see here. So it is one of the relations of the orbital roof, and also the relations of the medial wall. And finally, below the roof will be the lacrimal gland and the lacrimal nerve. So here is the lacrimal gland, and this is the lacrimal nerve supplying it. It will be just below the lateral, or just below the orbital roof from the lateral side. So again, lacrimal frontal supraorbital vessels. Then below them will be levator, below them will be superior rectus, and in the medial wall it will be the superior oblique, and the lateral wall at the junction between the roof and lateral wall will be the lacrimal gland and lacrimal nerve. Now we come to the orbital floor. So the orbital floor is made of which bones? It will be made of an orbital plate of maxillary bone, which is located anteromedially. So the maxilla sharing the formation of the the floor. Then the orbital plate of zygomatic bone, which is sharing the formation of the floor and the lateral wall. And finally, there are very small bone located posteriorly called the orbital process of palatine bone. So again, this is the floor. The floor is made of, here is if we remove the roof and the eye globe, and we will look at the floor from above, so we will find that there is a bone forming the anteromedial part of the floor called the orbital plate of maxilla. Laterally, there will be an orbital plate of zygomatic bone, and as you can see, there is a groove separating both of them. It's called the infraorbital groove. And finally, there is a small triangular piece of bone located posteriorly. It is called the palatine bone. So what are the features? Again, what are the features that distinguish the orbital floor? So there is an important fissure here called the inferior orbital fissure or the infraorbital fissure. The inferior orbital fissure extends across the floor of the orbit until it reaches the superior orbital fissure here. So there is inferior orbital fissure and superior orbital fissure. And its function is that it will transmit the infraorbital nerve and artery to emerge from the infraorbital foramen of the rim, as we said earlier. It is separated, or the floor is separated from the lateral wall by the inferior orbital fissure, as we said here. So this is the floor, and this is the lateral wall, and they are separated from each other by the inferior orbital fissure. However, this is only posterior, but anteriorly, they are both joined together. So the maxilla will be joined by the zygomatic bone anteriorly, while the medial wall, or it is separated from the medial wall by just a fine suture separating the floor from the medial walls. So what are the relations of the floor? So just below the floor, as you may expect, it will be the maxillary sinus, while above the orbital floor will be the two muscles, the inferior oblique and the inferior rectus, as you can see here. And as a general rule, the obliques are always below the recti. So the inferior oblique will be the first one, then it will be the inferior rectus. Then there will be a branch of that from the oculomotor nerve will supply the inferior oblique muscle. It is called the nerve to inferior oblique, will be also situated above the floor, while the infraorbital nerve and the infraorbital artery, as you can see here, also will be located above the floor. Then we come to the medial wall. So the medial wall is a quadrangular, as we said earlier, and it is formed by 4 bones. These 4 bones are arranged from anterior to posterior. Are first the frontal process of maxillary bone, then posterior to it will be the lacrimal bone, and posterior to it will be the orbital plate of ethmoid bone, and finally we reach to the body of sphenoid bone. So the body of sphenoid bone make a part of the medial wall. So remember that the lesser wing make a part of the orbital roof, while the body of sphenoid make a part of the medial wall. Here is the medial wall of the orbit. So if we have a lateral view, so we will see that there is a frontal process of maxilla here, and this frontal process of maxilla will give rise to the anterior lacrimal crest. Then we have the lacrimal bone, and this lacrimal bone will feature the posterior lacrimal crest. And between the anterior lacrimal crest and the posterior lacrimal crest will be the lacrimal fossa, in which the lacrimal sac will be located. Then we have the orbital plate of the ethmoid bone, and this bone is very thin, is sometimes called the lamina papyracea, and the clinical importance of this bone that since it is very thin, sometimes it can transmit infection from ethmoidal sinusitis, which will be one of the commonest predisposing factor to orbital cellulitis, especially in children. Then we have the body of sphenoid bone. Here we can see the body of sphenoid bone. So again, the medial wall is formed by the frontal process of maxilla, lacrimal bone, orbital plate of ethmoid bone, and the body of sphenoid bone. So what are the features? As we said, the frontal process of maxilla will make the anterior lacrimal crest, while the lacrimal bone will make the posterior lacrimal crest, and the lacrimal fossa will be located between both of them. Then we have the orbital plate of ethmoid, which features the lamina papyracea. Sometimes it is very thin, as we said. Then finally, we have the body of sphenoid bone. That body of sphenoid bone will carry the optic foramen. So the optic foramen is present in the body of sphenoid bone. Again, the body of sphenoid bone will feature the optic foramen, which will transmit the optic nerve. Let's now see what are the relations of the orbit. Medially, so the medial relation to the orbit or to the medial wall, so it will be logic that this is the medial wall and this is medial. So medially will be just the nasal lateral wall of the nose and the ethmoidal sinuses anteriorly and the sphenoidal sinus posteriorly. So this is the medial relation of the medial wall. So what are the lateral relations, which is the most important? We have the medial rectus along all the medial wall, and we have the ophthalmic artery, ethmoidal artery, and the ethmoidal nerves, and the infratrochlear nerve. And we have the muscle cut from here. It's called the superior oblique, and this superior oblique run at the corner between the medial wall and the roof, as we said before. And finally, we have the lacrimal sac, and the lacrimal sac is located, as we said, at the medial wall. So it is lateral to the medial wall. So as we said, the medially will be the lateral wall of the nose, the ethmoidal sinus, and the sphenoidal sinus, while lateral to the medial wall, you can find this medial rectus along the whole length of the medial wall. Then we have the superior oblique at the corner between the roof and the medial wall. We have the ethmoidal vessels and nerves supply the ethmoidal sinuses, so they will be again lateral to the medial wall. And we have the the lacrimal sac, which is located at the lacrimal fossa. So here is the lacrimal sac. It is located medially, as you can see here. So it is lateral to the medial wall. Finally, we have the lateral wall. So the lateral wall is made of two bones, just the zygoma anteriorly and the sphenoid bone posteriorly. But which part of the sphenoid bone? It will be the greater wing of the sphenoid bone. So to summarize, we have now the lesser wing of sphenoid making a part of the orbital roof. We have the lesser wing of sphenoid making a part of the medial wall, and we have the greater wing of sphenoid making a part of the lateral wall. So I hope that it's clear. If we have a section of the medial wall, so we can see that there is formed by the zygomatic bone anteriorly and the greater wing of sphenoid posteriorly. So these bones are making the lateral wall. What are the important features? So here is the zygoma. The zygoma is a very tough bone, very thick bone, because it shall protect the eye from lateral trauma. So it will be a thick bone that separates the orbit from a fossa called the temporal fossa below the temple, and it features a tubercle. This tubercle, it is present at the lateral orbital margin. It is called the Whitnall tubercle. Whitnall tubercle or lateral orbital tubercle, it is one of the commonest areas of questions in the exams, because there are some important structures attached to it, all of them with letter L. So the Whitnall tubercle, attached to it the levator palpebrae aponeurosis and the lockwood ligament, which sometimes called the suspensory ligament of the globe, the lateral rectus check ligament, and lateral palpebral ligament. We will discuss these later on. But the issue here, that did we say that it is attached to Whitnall ligament? So the answer is no. And this is how the examiner confuse you. So he brings to you some options, and including with them the Whitnall ligament. So the trick here is that the Whitnall ligament is not attached to the Whitnall tubercle. So Whitnall ligament is located away from the Whitnall tubercle. And what are the important features, other important features of the lateral wall? So we have the zygomatic groove. This zygomatic groove, which arises from the anterior end of the infraorbital fissure, and it will transmit the zygomatic nerve. Finally, the greater wing of sphenoid, here is the greater wing of sphenoid, will separate the orbit from the middle cranial fossa, and there will be some bones or small bony projection at the inferior margin of the superior orbital fissure. This is called spina recti lateralis. These spina recti lateralis are small bony projections that has an importance in giving attachment to the lateral rectus muscle. So the lateral rectus muscle takes part of its attachment or part of its origin from the spina recti lateralis present in the inferior margin of the superior orbital fissure. So here you can see this is the lateral or the Whitnall tubercle, or what's called the lateral orbital tubercle, and attached to it different structures. What are these structures? The levator muscle give aponeurosis that give this aponeurosis has 5 attachments. One of them is the lateral orbital tubercle or the Whitnall tubercle. Then the lockwood ligament or the suspensory ligament of the globe again give attachment to the lateral orbital tubercle. The lateral rectus check ligament. So each rectus muscle has a check ligament. We will discuss it later. And this ligament also is attached to the lateral orbital tubercle. And finally, the lateral palpebral ligament, or sometimes it is called the lateral canthal tendon, which attach the tarsus to the lateral orbital margin. This tendon or this ligament is also attached to the lateral orbital tubercle. However, as you can see here, this is the Whitnall ligament, which is away from the lateral orbital tubercle. So we mentioned something about the zygomatic groove. What is the zygomatic groove? So the zygomatic groove here, it is a groove which arises from the anterior end of the inferior orbital fissure. So here is the superior orbital fissure. Here is the optic canal. Here is the inferior orbital fissure. And from the inferior orbital fissure, there is a canal or a groove that this groove will have a foramen called the zygomatic foramen. And then it will be closed to form a canal inside the bone. It's called the zygomatic canal. This zygomatic canal will transmit the zygomatic vessels and the nerves, and within the bone of the zygoma, it will divide into 2 bones, or 2 canals. The first one will transmit the zygomatico-fascial vessels and the nerve, and it will open into a foramen into in the zygomatic bone. It's called the zygomatic fascial foramen. And the other canal, it will transmit the zygomatico-temporal vessels and the nerve, and it will open into the temporal fossa by an opening called the zygomatico-temporal foramen. So again, from the inferior orbital fissure, we have the zygomatic the zygomatic foramen. It will then make a canal, forming the zygomatic canal, that will transmit the zygomatic vessels and nerve. These vessels and nerves will be divided into to arise from the face into zygomaticofacial foramen and into the temporal fossa in the form of zygomaticotemporal vessels and nerves. So finally, what are the relations of the lateral wall? What will be the lateral to the lateral wall? We have the temporal fossa. So the temporal fossa will be anteriorly or located outside the lateral wall, and posteriorly we have the middle cranial fossa here. So here will be the temporal fossa, and here we'll have the posterior cranial fossa. And what are the structures that are located medial to the lateral wall? So we have the lateral rectus along the lateral, all the length of the lateral wall, and above the lateral rectus there will be vessels and nerves are called the lacrimal artery and lacrimal nerves. These lacrimal artery and lacrimal nerve are running above the superior border of the lateral rectus muscle to supply the lacrimal gland. So this is the orbital walls. So to summarize the orbital walls, we have the roof, medial wall, the floor, and lateral wall. So the roof is made of the frontal bone or the orbital plate of the frontal bone and lesser wing of sphenoid bone. We have the medial wall formed by the frontal process of maxillary bone, lacrimal bone, ethmoid bone, and the body of sphenoid bone. The floor is made by the maxillary bone, the zygomatic bone, and palatine bone. And finally, the lateral wall is made by zygomatic bone and the greater wing of sphenoid bone. So is everything clear up till now? Does anyone have any question? The Whitnell ligament is a part of the orbital fascia. It is a superior ligament, so sometimes it has a significant importance in the oculoplastic surgery. So, for example, if you are doing levator resection or the levator resection for ptosis, then our maximum resection will be marked by the Whitnell ligament. So when we reach the Whitnell ligament, we know that this is the maximum part of the muscle that we can resect for the ptosis surgery. So it is just superior to, it is located superiorly and not attached to the lateral orbital tubercle. Okay, so we will continue the orbit. So after finishing the lateral or the orbital walls and the orbital rim, we will need now to know what are the important foramens that present in the orbit. One of the most important is the optic foramen. So optic foramen is the orbital opening of the optic canal. So we have a canal inside the bone, like here, the canal that pass within which this pen pass. It has an orbital opening toward the orbit and the cranial opening toward the brain. The cranial opening is called the orbital opening will be called the optic foramen. Where it is located? It is located posterior medial portion of the orbit. So it's located posteriorly, making a part of the orbital apex, and it is located more medially in the body of sphenoid bone. As we said in the walls, it is made by the body of sphenoid bone. So this is the optic canal, as you can see here. And this is the sphenoid bone. The sphenoid bone here, you can see it separates the anterior cranial fossa from the middle cranial fossa. And it is made mainly by three main bones. It is the greater wing and the body and the lesser wing. This is the lesser wing. So this optic canal will transmit the optic nerve, and this optic canal will be communicating the orbital space to the middle cranial fossa, as we can see here. So this is the anterior cranial fossa. This is the middle cranial fossa. This is the passage of the optic nerve. Here again, this is the this is the zygomatic bone. This is the body containing the optic foramen, and this is the lesser wing, and this is the greater wing. Here, try to concentrate with me. Where it is, the optic canal is located within the body of a sphenoid. But what are the boundaries? What make the boundaries of the optic canal, or what will be the edges of the optic canal? It will be the two roots of lesser wing of sphenoid. So here is the lesser wing of sphenoid, and this is the another lesser wing of another root of the lesser wing of sphenoid. This is the anterior root, and this is the posterior root. If you check for the optic canal, it will be located between both roots of the lesser wing of sphenoids. So will be located between the two roots of the lesser wing of the sphenoid. Medial to it will be the sphenoidal sinus posteriorly, and sometimes the posterior ethmoidal sinus more anteriorly. Lateral to the optic canal will be the posterior root of the lesser wing of sphenoid, as you can see here. So this is the optic foramen, and this is the posterior root of the lesser wing of sphenoid, which has carry an important anatomical landmark that it will separate the optic canal from the superior orbital fissure. So here is the superior orbital fissure, and here is the optic canal. Separating both of them will be the posterior root of the lesser wing of sphenoid. Above the lesser wing of sphenoid will be what's called the gyrus rectus and the olfactory tract. So just imagine that this is the sphenoid bone, and it is a 3D bone. So here is what are these openings? These are the ethmoidal, the sphenoidal sinuses. And here you can see this is the lesser wing of sphenoid, and here is the optic canal. This is the optic canal, and this is the optic canal, and it is separated from the superior orbital fissure by the posterior root of the lesser wing of sphenoid. But the optic canal itself, it is located within the body of sphenoid bone. I hope that this is clear. So here is the sphenoidal sinus, and here is above the optic canal will be the orbital gyrus and the olfactory tract. What is the direction of the optic canal? It will be directed forward, laterally, and slightly downward, which is the same direction of the orbit itself. Forward, laterally, and slightly downward. So what are the most important thing about the foramens are what are the structures that are passing through them. So what are the structures that pass through the optic canal or optic foramen? First of all, it will be the optic nerve, because it is made for it. It is named after it. Then we have an artery that has a close relation to the optic nerve, which is called the ophthalmic artery, and we will discuss its course in details regarding the optic nerve. So it will be lateral, then cross above, then will cross medial, as we will see later on in the vascular lecture. Then we have the sympathetic nerves from the carotid plexus pass within the carotid artery. As the ophthalmic artery is a branch from the internal carotid artery, the sympathetic plexus are passing with the internal carotid artery and its terminal branches. So the sympathetic nerves are passing within the ophthalmic artery. So again, if we have a section here of the orbit, we can see that this black ring is the optic foramen. It will transmit the optic nerve and the ophthalmic artery, and finally the sympathetic fibers. Optic nerve, ophthalmic artery, and sympathetic fibers. Okay, so another structure which is important and located at the orbital apex and has relation to the optic foramen will be called the annulus of Zinn. What is the annulus of Zinn? Sometimes it's called the common tendinous ring, or it's called annulus of Zinn, or the annular ring. All these names are belonging to the same structure. This structure is simply thickening of the orbital fat. So for the orbital fat or the orbital fascia, it is termed preorbita. So preorbita meaning that it is orbital fascia. Thickening of the orbital fascia at the apex of the orbit, it is called the annulus of Zinn or the common tendinous ring. This is present at the apex of the orbit, and it has an important function of giving rise to the origin of extraocular muscles. So here is the optic nerve surrounded by the common tendinous ring, and as you can see here that the extraocular muscles are arising from it. So this is called the extra or the common tendinous ring or annulus of Zen, giving rise to the origins of extraocular muscles. So what is the relation between this common tendinous ring and the optic foramen? Well, the optic foramen is lying inside the common tendinous ring. So what is this structure? This coma-shaped structure. This is the superior orbital fissure. So as you can see here, there are some structures that are located inside the superior orbital fissure and the common tendinous ring, and there are structures that are located into the superior orbital fissure but outside the common tendinous ring. And we will discuss this later on in a few minutes. So the superior orbital fissure. What is the superior orbital fissure? So this fissure is present at the orbital apex between the roof and the lateral wall. So here is the roof, and here is the lateral wall. This superior orbital fissure will separate the two parts of sphenoid bone, so it will separate the lesser wing of a sphenoid from the greater wing of a sphenoid. So as you can see here, this is the optic foramen transmitting the optic nerve, and this is the lesser wing of a sphenoid, and this is the greater wing of a sphenoid. Between them, our fissure is called the superior orbital fissure. This superior orbital fissure will communicate the orbit to the middle cranial fossa as well as the optic foramen, and it has a longitudinal axis of about 22 millimeters. It has a shape of coma-shaped or elongated shape that has become more wider medially than laterally. So it's becoming more wider in close proximity to the optic canal, but laterally it become more narrow. So what are the boundaries of the superior orbital fissure? Above the superior orbital fissure will be the posterior root of the lesser wing of sphenoid. So you remember when we said in the optic foramen, we said that the posterior root of the lesser wing of sphenoid will separate the optic canal from the superior orbital fissure. And we have this tubercle, this is called the infraorbitic tubercle because it's located below the optic nerve. It will be called infraoptic tubercle, which is present just below and lateral to the optic foramen. About the posterior boundary of the superior orbital fissure, it will be the greater wing of sphenoid, as you can see here, and the spina recti lateralis, as we mentioned, the spina recti lateralis are present in the junction between the medial and lateral parts of the superior orbital fissure, and they have an importance of giving attachment to the lateral rectus muscle. And laterally, it will be closed by the frontal bone. Medially, the superior orbital fissure will be continuous with its brother. It is the inferior orbital fissure, and we will discuss it later on. So what are the structures that are attached to the superior orbital fissure? As we said, we have small bony projections over in the margin of the superior orbital fissure called the spina recti lateralis. These spina recti lateralis give rise to attachment of the common tendinous ring or the annulus of Zen here, and also can give attachment to the lateral rectus muscle. So the lateral rectus muscle, which is here, the lateral rectus muscle has two origins. It originates from the lateral wall. It originates from the annulus of Zen, and also originate from the spina recti lateralis. So here we come to one of the most important slides in our lecture today, which will be the structures that are passing through the superior orbital fissure. So here is the superior orbital fissure, which transmit large number of vessels, nerves, and veins and arteries. And it is one of the hot topics in the exams to be asked about what are the structures that pass through the superior orbital fissure. These structures can be divided by the attachment of the tendinous ring into structures passing above it and structures passing below the common tendinous ring and structure passing within the common tendinous ring. So what are these structures? First, we have lacrimal frontal trochlear nerves. The lacrimal nerve, the frontal nerve, and the trochlear nerve pass above the common tendinous ring within the superior orbital fissure. Then we have an artery and vein. The artery is the recurrent meningeal branch, and the vein is the superior ophthalmic vein. So if we say superior ophthalmic vein, then we will have an inferior ophthalmic vein, but the inferior ophthalmic vein will be transmitted below the common tendinous ring. So whether these structures above or this structure below, these structure pass through the superior orbital fissure, but don't pass through the common tendinous ring. So what are the structures that pass through the common tendinous ring? We have just mentioned that the optic nerve, ophthalmic artery, and the sympathetic fibers are within the common tendinous ring. And this common tendinous ring includes some of structures present in the superior orbital fissure. This will be the superior division of oculomotor nerve and the inferior division of the oculomotor nerve, nasociliary nerve, and abducent nerve. So in order to memorize these structures, we can remember it by what are the structures that pass through the superior orbital fissure by this mnemonic. Live free to really see no insult at all. L for lacrimal nerve, F for frontal nerve, T for trochlear nerve, R for recurrent meningeal artery, S for superior ophthalmic vein. So these are the structures passing above the annulus of ring. Structures passing inside the annulus of ring will be C, S for the superior division of the oculomotor nerve, N for nasociliary nerve, I for the inferior division of the oculomotor nerve, A for abducent nerve. So these are the structures passing inside and outside the common tendinous ring. So again, here we have the common tendinous ring, and this is the superior orbital fissure. We have lacrimal frontal trochlear nerve, recurrent meningeal artery, superior ophthalmic vein, and below will be the inferior ophthalmic vein, and the inside will be the structures passing through the optic canal, which are the optic nerve, ophthalmic artery, and the sympathetic fibers. And we have the superior and inferior divisions of the oculomotor nerve. We have the abducent nerve and the nasociliary nerve. So this is one of the very, very important slides that you need to memorize very well. Then we will come to the inferior orbital fissure. So the inferior orbital fissure is located between the floor and the lateral wall. As we said, it will separate the floor made by the maxilla and the lateral wall made by the greater wing of sphenoid. The inferior or the infraorbital fissure will communicate the orbit, but not to the middle cranial fossa as usual, but it is located inferiorly. So it will communicate the orbit to other two fossa, which are the pterygopalatine fossa, which contain the pterygopalatine ganglion and the pterygopalatine venous plexus that we will discuss later on, and the infratemporal fossa. So the infraorbital fissure will communicate again the orbit to the pterygopalatine fossa and the infratemporal fossa. What are the boundaries? So anterior to the infraorbital fissure will be the orbital plate of maxilla, this green one, and the orbital plate of palatine bone, this triangular piece of bone. While posteriorly, there will be the orbital plate of greater wing of sphenoid. So remember that this yellowish bone, this is the greater wing of sphenoid. So again, anteriorly will be the body of maxilla and the palatine bone, and posteriorly will be the greater wing of sphenoid. Laterally, it will be sharp and higher than the medial border here. And this fissure will be closed by the periorbita and the molar muscle. The direction of the infraorbital fissure will be forward and laterally, as you can see here. And here we come to the structures passing through it. So here is the infraorbital fissure. And from it, there is an infraorbital canal, as you can see here. So there was a nerve that entered into the infraorbital fissure. It is called the maxillary nerve. Then this nerve will pass through the infraorbital groove and the infraorbital canal as an end branch, or the continuation of the maxillary nerve will be called the infraorbital nerve. The infraorbital nerve will pass through the infraorbital groove, which will be closed to form an infraorbital canal to emerge from the cheek from the infraorbital foramen. So again, the infraorbital fissure will transmit the maxillary nerve that will continue as infraorbital nerve within the infraorbital groove. This groove will be closed to form the infraorbital canal that will emerge from an infraorbital foramen just below the inferior orbital margin as an infraorbital nerve. Also, it will transmit the supraorbital vessels, supraorbital artery, and supraorbital vein, and it will transmit some emissary veins. So these veins perforate the bone to communicate between the ophthalmic vein and the pterygoid venous plexus, called emissary veins. So what are the structures again? Passing through the inferior orbital fissure, maxillary nerve and its continuation with the infraorbital nerve, zygomatic nerve, emissary veins, infraorbital artery and vein. And finally, there will be a nerve called orbitociliary nerve, which is a branch from the mandibular nerve. We have finished the important foramens. So these are the superior orbital fissure, inferior orbital fissure, and the optic nerve or the optic canal are the commonest areas to be asked in the exam. But we have other small foramens in the orbit that will just know some basic or some very few information about it. So we have ethmoidal foramina. The ethmoidal foramina are present into the medial wall, so because they are present into the ethmoidal bone. So they will separate the roof from the medial wall, and they are located into the sutures between the frontal and the ethmoidal bones. These foramina communicate the orbit to the anterior cranial fossa. So to remember, we have now the optic canal and the superior orbital fissure will communicate the orbit to the middle cranial fossa. We have the infraorbital fissure that communicates the orbit to the infratemporal fossa and the pterygopalatine fossa. And we have the ethmoidal foramina that will communicate the orbit to the anterior cranial fossa. So from just your basic understanding of what we mentioned, so you will be able to guess what are the structures passing through the ethmoidal foramina. So that's correct. It will be the ethmoidal vessels and the nerves. So they will transmit the ethmoidal arteries and the ethmoidal veins and the ethmoidal nerves that will supply the ethmoidal sinus. Other foramina outside the orbit, we have mentioned about them, which are the supraorbital foramen and the supratrochlear groove. So we have the supraorbital foramen, which transmits the supraorbital vessels and the nerve. We have the Arnold foramen, which is sometimes located medial to the supraorbital foramen, and it will transmit medial branches from the supraorbital vessels and nerves. We have the supraciliary canal, which is present also in 50% of individuals near the supraorbital foramen, which will transmit the supraorbital nerve to the frontal ear sinus. And we have the infraorbital foramen, which will transmit the infraorbital vessels and nerve. So, as we said, the infraorbital foramen, from the inferior orbital fissure, the zygomatic canal will arise from the infraorbital fissure, and it will transmit the infraorbital nerve. And this zygomatic canal will emerge from the one below the cheek, which is the zygomatic fissure foramen, and another one called the zygomatic-temporal foramen. The final part of the orbit will be the orbital fascia, or or what's called the periorbita. So the periorbita is just it is the lining of the orbital wall. So the wall of the orbit, it is lined by a tissue called the periorbita, or the periosteum of the orbit. This periosteum of the orbit is derived mainly from the dura mater, meaning that the dura mater will be covering the optic nerve, and until it reaches the apex of the orbit, they are divided into two layers. One layer will cover the optic nerve, and the other layer will be line the bones of the orbit, and they are called the periosteum of the orbit. So one of the parts of the orbit, one of the main contents of the orbital fascia is the periorbital. And where is the periorbital derived from? It is derived from the dura mater. Another important structure from the orbital fat will be the orbital septum, and this will divide the lid or divide the orbit into anterior and compartment and posterior compartment, and this will be discussed in details tomorrow in the lid lecture. Then we have some fascial sheath or some bulbar fascia. So this bulbar fascia is called the tenon capsule. The tenon capsule is a fascial capsule that is located just beneath the conjunctiva anteriorly and enclose the extraocular muscle posteriorly. So you can see this is the tenon capsule. This is the posterior tenon covering the posterior part of the globe, and this is the cut section of the superior oblique muscle. And as you can see that the tenon is enclosing it and enclosing the superior rectus from above and below, and so these are the posterior extension of the tenon capsule or the posterior tenon. While the anterior tenon, it is just move anteriorly until it is reached the corneoscleral limbus. So here is the anterior tenon covering the bulbar conjunctiva until it reaches the corneoscleral limbus. This is more evident in the cut section here. So in the cut section, you can see this is the tenon capsule, and it encloses the extraocular muscle. So this is one of the main functions of the tenon capsule. It encloses the extraocular muscles to allow free movement of these muscles and facilitate their movement. Here is this is the tenon capsule, and this tenon capsule will enclose or has perforations. So it will have perforations for the extraocular muscles, the 6 extraocular muscle from anterior, and posteriorly will have perforations for the optic nerve, ciliary vessels and nerves, and the vortex veins. You can see that there are some thickening of the orbital fascia or the bulbar fascia or the tenon capsule that is located at the extraocular muscles. These fascial thickening at the extraocular muscles are called the check ligaments. So we have lateral check ligament, medial check ligament, superior and inferior. And what are these for the functions of the muscle fascial ligaments? These fascia these check ligaments are to prevent the free mobility or the total free mobility of the recti, or to stop the motility of the extraocular muscle at a certain limit. So for example, if you are looking to laterally or to medially, what will prevent the eye from rolling backward? So your cornea will be toward the optic nerve. Can this occur? The answer is no, because the lateral and the medial movements have their limit. And what is the limit? This is by check ligament. So the check ligament this is a fascia that will attach the muscle to the orbital margin and will limit the movement of the muscle. There are so this is the check ligament of the medial rectus, and this is the check ligament of lateral rectus. We have other fascia of the orbit, like the superior rectus expansion. So the superior, the revetropalpebral superiosis, this muscle, and the underlying superior rectus are joined by a common sheath. So this sheath will lead to a synergistic action between both of them, meaning that if you are looking upward, and you move your eyeball upward, you will find that the upper eyelid is elevated automatically. And this is because of the attachment between the levator muscle and the superior rectus muscle. The same thing occurs inferiorly. So there will be fascial expansion between the inferior rectus muscle and the lower lid. So when you are depressed, you're looking downward, there will be depression of the lower eyelid. There will be another expansion of the muscle fascia at the medial wall here. It is called the trochlea. As we said, it is a cartilaginous fascia that transmits the superior oblique tendon And finally, we have the inferior oblique expansion that will share in the formation of suspensory ligament of the globe, joining the or the lockwood ligament, which is attached to the retinal tubercle. So this is a ligament will join the inferior rectus and the inferior oblique together. So is everything clear up till now? So let me show you some nice videos to summarize what we have mentioned in the orbital lecture. So you may see this lecture, see these videos. Here is the orbit, and this is the supraorbital foramen, the ethmoidal bone, lacrimal bone, nasal bone, zygomatic-temporal, and the foramen, and the zygomatic bone, zygomatico-fascial foramen, infraorbital foramen, and the maxillary bone. This is the medial wall, the quadrangular bone made of the frontal process of maxilla, lacrimal bone, ethmoidal bone, and the sphenoidal bone. Then we have the roof made of the the orbital plate of frontal bone and the sphenoidal bone. So let's see the next one. This this video for the contents of the superior orbital fissure and the common tendinous ring. So let's have a closer look. So here we have, this is the optic canal, this is the superior orbital fissure, and this is the common tendinous ring. Above it will be the frontal nerve, lacrimal nerve, and the supratrochlear nerve, and the superior ophthalmic vein and the recurrent meningeal artery. Inside will be the optic nerve, and the superior and inferior division of the oculomotor nerve, the nasociliary nerve, and the abducent nerve. And below will be the inferior ophthalmic vein. Finally, this is the final video for the orbit lecture. You can watch it, and it is about 10 minutes. Then we will take a break for another 10 minutes. Then we will back for the extraocular muscles anatomy. So enjoy this video for the main or some important anatomical consideration of the orbit.
Hi, this is Peter from Anatomy Zone, and in this tutorial we will be taking a look at the anatomy of the bony orbit. This video is a collaboration between Anatomy Zone and teachmeanatomy.info. Check out the links in the video description below for some useful articles to accompany this video tutorial. The bony orbits, or eye sockets, are bilateral and symmetrical cavities in the head. They enclose the eyeball and its associated structures. The orbit can be thought of as a pyramidal structure, with the apex pointing posteromedially into the optic foramen, and the base situated anteriorly, opening up into the face and formed by the orbital rim. The boundaries of the orbit are formed by 7 bones. From this anterior view, you can see the frontal bone in red, the maxilla in purple, the zygomatic bone in light blue, the sphenoid bone posteriorly in yellow, and the ethmoid bone in orange. Looking here at the medial aspect of the orbit, you can see a better view of the lacrimal bone in green, the ethmoid bone in orange, and a small part of the palatine bone in dark blue. Let's take a look at the base of this pyramid and the boundaries of the orbital rim. Starting superiorly, you can see this border formed by the frontal bone. The medial border is formed by the frontal process of the maxilla. The inferior border is formed by the zygomatic process of the maxilla and the zygomatic bone. The lateral border is formed by the frontal process of the zygomatic bone and the zygomatic process of the frontal bone. Now let's take a look at the other components of the bony orbit. The roof, or the superior wall, is formed by the frontal bone and the lesser wing of the sphenoid. The frontal bone separates the orbit from the anterior cranial fossa. I've just switched to a view to demonstrate the sphenoid bone, which can be a confusing bone to understand. From this anterior view, you can see the lesser wing, the greater wing, and the superior orbital fissure. And to illustrate this from within the cranium, I've rotated around to show these structures from a posterior and internal view. The floor, or inferior wall, is formed by the maxilla, the palatine and zygomatic bones. The maxilla separates the orbit from the underlying maxillary sinus. The medial wall is formed by the ethmoid, the maxilla, the lacrimal and sphenoid bones. The ethmoid bone separates the orbit from the ethmoid sinus. The lateral wall is formed by the zygomatic bone and the greater wing of the sphenoid. The apex of the orbit is located at the opening to the optic canal, which is known as the optic foramen. The base, as we have seen, opens out into the face and is bounded by the eyelids. It is also known as the orbital rim. Let's take a quick look now at the contents of the bony orbit. The bony orbit contains the eyeballs and their associated structures. These include the extraocular muscles, the eyelids, and several nerves and blood vessels. The extraocular muscles are responsible for the movement of the eyeball and the superior eyelid. We'll take a look at the extraocular muscles in the next tutorial. In terms of the nerves within the bony orbit, there are several cranial nerves which supply the eye and its structures. These include the optic, the oculomotor, the trochlear, the trigeminal, and the abducens nerve. There are also several blood vessels within the bony orbit. The eye receives blood primarily from the ophthalmic artery. Venous drainage is via the superior and inferior ophthalmic veins. Let's take a look now at the pathways into the orbit. There are three main pathways by which structures can enter and exit the orbit. These include the optic canal, the superior orbital fissure, and the inferior orbital fissure. The optic canal transmits the optic nerve and the ophthalmic artery. It opens into the middle cranial fossa. The superior orbital fissure lies laterally to the optic canal and transmits several nerves, including the lacrimal, the frontal, the fourth cranial nerve, which is the trochlea, the superior and inferior branches of the oculomotor nerve, which is cranial nerve 3, the nasociliary branches of the ophthalmic nerve, which is the first branch of the trigeminal nerve, cranial nerve 5, and it also transmits the abducens nerve, cranial nerve number 6. In addition, it also carries the superior ophthalmic vein. The inferior orbital fissure separates the lateral wall of the orbit from the floor of the orbit. This fissure transmits the zygomatic branch of the maxillary nerve, which is the second branch of the trigeminal nerve, cranial nerve 5, as well as the maxillary nerve itself. In addition, it transmits the inferior ophthalmic vein and also some sympathetic nerves. There are also some other minor openings into the orbital cavity. The nasolacrimal canal, which drains tears from the eye to the nasal cavity, is located on the medial wall of the orbit. Other small openings include the supraorbital foramen and the infraorbital foramen, which transmit small neurovascular structures. The infraorbital groove begins posteriorly at the inferior orbital fissure and passes across the floor of the orbit to connect with the infraorbital canal, which then opens up onto the face via the infraorbital foramen. So that's the anatomy of the bony orbit. For more anatomy articles, check out teachmeanatomy.info, and for more anatomy videos and flashcards, check out anatomyzone.com. If you have found this video useful, click on the like button below and subscribe to Anatomy Zone for more video tutorials. Thank you for watching.
So thank you for watching. This is the end of our first lecture. So we'll have a break now for about 10 minutes. Then we will be back for the extraocular muscle anatomy. Thank you for your attention, and see you in 10 minutes.